are coming from the oral session in gastric cancer, so it was really nice to listen to the presentation by Dr. Elimova. This is a practice-changing trial in the first-line setting of HER2-positive gastroesophageal adenocarcinoma. And this study enrolled the patients with HER2-positive, centrally confirmed gastroesophageal adenocarcinoma, irrespective of PD-L1 expression, and patients were randomized to either chemotherapy plus trastuzumab, which was the standard of care at the time of the study design, versus 2 experimental arms with chemotherapy plus zanidatamab, so basically replacing trastuzumab with zanidatamab, or even a combination with a PD-1 inhibitor, Tislelizumab plus zanidatamab and chemotherapy. And so basically the co-primary endpoints of the study were progression-free and overall survival, and the study was positive since progression-free survival was actually significantly better in the 2 experimental combinations compared to trastuzumab and chemotherapy, and in particular it was 12 months in the Tislelizumab, zanidatamab, and chemotherapy combination. So also overall survival was significantly improved in the experimental arm with Tislelizumab and zanidatamab combination, and this is a new benchmark since median overall survival for this combination achieved 26.4 months, so more than 7 months improvement compared to the control arm. And in the other experimental arm with the chemotherapy and zanidatamab, there was a numerical improvement in terms of overall survival. This is still not statistically significant yet, but this is just the first interim analysis, so we will see with additional follow-up whether this additional experimental arm will be superior compared to trastuzumab and chemotherapy. Of course, this study should be interpreted in light of the current standard of care, which is the combination of pembrolizumab and trastuzumab and chemo, based on the KEYNOTE-811 study. And so, of course, the control arm of the study was a little bit outdated. But anyway, this is a new benchmark, and also the hazard ratio for overall survival and progression-free survival indirectly compare in a favorable manner with the KEYNOTE-811 study. So, of course, zanidatamab, in my opinion, will replace trastuzumab, especially when combined with immunotherapy in HER2-positive disease. So this is exciting news for patients because, of course, it's lovely to see hazard ratio for overall survival of 0.72, which is really amazing and definitely better than the KEYNOTE-811 data. Of course, we should be aware of the possibility of increased incidence of diarrhea with the use of zanidatamab, and this will require prophylactic treatment with loperamide, but also close monitoring of this class-specific side effect of zanidatamab. But in the clinical practice, I think it will be feasible and appropriate for most patients, so we will be happy to treat our patients as soon as the agent will be available in the clinical practice.